So the first specimen is an ascites specimen from a 63-year-old female. She presented with bowel obstruction. So in the specimen, I think we don't see normal component. We see mostly cohesive cells with pretty big nucleus. The nuclear feature shows vesicular chromatin at small but distinct nucleolus. The cytoplasm show large vacuole and with a very cohesive three-dimensional architecture. So this is compatible with adenocarcinoma. So the patient showed bowel obstruction. However, she also had a past history of endometrial cancer, but the endometrial cancer is high-grade serous. It's a high-grade serous carcinoma arising in the endometrial cavity. So this seems to be a recurrence disease with bowel involvement, so showing the bowel obstruction. She has admitted in our CRS colorectal surgeon admission, but I think it's the obstruction is due to gynecologic cancer. So it doesn't look like intestinal type adenocarcinoma, and the morphology is compatible with high-grade serous carcinoma. So this is the recurrence of the previous cancer. So this is the specimen that we see yesterday. So we move to the fine needle aspiration. The patient is under hemodialysis and he has been received fine needle aspiration for a thyroid nodule, and we identify these prominent papillary growths, but the nuclear features show very bland, like a monotonous uniform feature. So this looks like a parathyroid tumor. So we use the residual liquid specimen to do a cytospin and to perform GATA3. So you can see all these lesional cells are positive for GATA3. So this is compatible with parathyroid gland hyperplasia secondary to the chronic kidney disease. Okay, so this is not a thyroid lesion. This is actually a parathyroid lesion. So by morphology, we are able to just make this distinction. If the clinician mess up with the location, we can actually recorrect it just based on the morphological pattern and with the support by the immunohistochemistry. So the next specimen is the US guided aspiration for a pancreatic head tumor. We didn't see a lot of cells. Most of the cells seems to be these this cluster actually looks a little bit abnormal. It has a vague honeycombing pattern, but the cells start to develop a little bit like a TPR with a little bit, a very mild disorganization. So this one is a little bit, shows some mild TPR, and so we were thinking about could this be a well-differentiated adenocarcinoma? And then we will see a very three-dimensional cluster, and this is also quite concerning. So again, we do see a very three-dimensional cluster with glandular features, so this is also very concerning. So it looks like it has some area demonstrate features of well-differentiated adenocarcinoma, and I think this cluster is quite convincing. So we do have a very big cells with very big nucleolus, and within this very tight three-dimensional cluster, the cells show marked polymorphism, including variation of the size of the nucleus. So you can see in one cluster there is a much smaller nucleus. Right next to it is a much bigger one. So this is 1 to 4. So this is positive for adenocarcinoma. So sometimes in the pancreas EUS aspiration, you really need to see and identify a more like a convincing area to make the definite diagnosis. So we also see, for some reason, some squamous cells, but we actually also see some stromal cell. So these can be from the duodenal wall, muscular wall, or these can also be the desmoplastic stroma. So this is positive for adenocarcinoma. So the next specimen is coming from a neck lymph node. On low power, we do see some lymphocytes in the background. However, the most striking feature is that we do see many large cohesive cellular fragment, which is totally abnormal in the lymph node. When you go to higher power, this cell does have some area showing these, we call this decapitated papilla. So I explained it yesterday, but I don't find a really good focus, so this one is pretty good. So we can see around like a 3/4 of the circumferential, they show this luminal border, but at the one of these like a side of the cluster, it is totally like a blunt. So this seems to be like the papilla, this detached papilla, or we call this decapitated papilla. So this is actually a feature of a papillary architecture, and which is quite common in the papillary thyroid carcinoma. Again, here is a smaller one. You see the lumen, and on the other side is like totally blunt. So we also see multinucleated giant cells. So overall, again, and here we do see a pretty good pseudo inclusion over here. So this is from the neck lymph node, and it looks like metastatic papillary thyroid carcinoma in the lymph node. The patient does has on the unilateral, on the same side, they does have a thyroid lesion suspect to be a papillary thyroid carcinoma. So sometimes the clinician will sample the thyroid nodule. Sometimes if they are pretty sure about the thyroid nodule is PTC, they already want to do the surgery, they will just sample the lymph node to check if they need to do the neck dissection at the same time. So this is positive. So possibly the clinician would need to do the neck dissection because it seems to be a very big metastatic lymph node. So the next specimen is coming from thyroid. So on low power, we do notice that it's quite cystic. We see cystic hemorrhagic background with a lot of hemosiderin-laden macrophages, as well as some quite dense colloid. And additionally, we do see some cluster of cells with similar feature that we just saw from the lymph node. So the nucleus is enlarged, is oval shape with irregular membrane and some groove. Here we see a pseudo inclusion. So this is compatible with a cystic papillary thyroid carcinoma. The cell is not very well preserved, but the background and the cells are totally abnormal. We don't have a lot of cells, but I think those two clusters are diagnostic despite these are not very well preserved. Here we also see a decapitated papilla pattern. So this is compatible with papillary thyroid carcinoma. So the next specimen is a breast aspiration cytology. On low power view, it is striking that it is so hypercellular. We see some cohesive larger fragment as well as background discohesive individual cell. So as we discussed yesterday, that if we see a lot of these cohesive ductal cells, it is highly suggestive that it is a carcinoma, ductal carcinoma with invasion. However, if you take a closer look, so we do have a nice ductal component. However, in the background, most of the individual cell seems to have naked nucleus and with elongated nucleus. And the nuclear chromatin pattern is much condensed compared to the ductal cell. So it looks like in the background, majority of the cells are myoepithelial cells. So the lesion has a very rich myoepithelial component. So here is a cohesive ductal component with a little bit very mild variation of nuclear size. However, it is relatively uniform with a very relatively organized arrangement. And in the background, we see a lot of myoepithelial cells. The amount of myoepithelial cells is a little bit exceeding the usual specimen that we see. So I'm suspect the lesion is actually adenomyoepithelioma because it has more myoepithelial cell than it should be. And it is also interesting that we see in this cluster, this is a ductal cell cluster with cohesion. And if we focus in up and down, you start to see these smaller ovoid cells with darker chromatin pattern. These are myoepithelial cells. So you see ductal cell and myoepithelial cell together, this is benign. And in the background, we do see like a lot of detachment of myoepithelial cell. So I think this is highly likely to be a adenomyoepithelioma. So on low power, it looks very concerning. It looks like an invasive carcinoma. However, on high power, we are able to make distinction that most of these cohesive individual cells are actually myoepithelial cells, not ductal cell. And we don't see like a severe TPR. So I think this is still benign because most of these larger cohesive fragments still have myoepithelial cell around it. But the problem is that there are just too many myoepithelial cells. So it is likely an adenomyoepithelioma. So we call these negative and we rule out adenomyoepithelioma. Finally, this is a pap smear from a 57-year-old female. So supposedly she already had menopause. So we see most of the cell looks like intermediate cell with very scant superficial cell compatible with the age. And so the background is pretty clean. So in this situation, we will usually look for either microorganism or the precursor lesion. So we start to identify some intermediate cells. This is a little bit overlapping. This is the problem for the conventional smear. However, you can still appreciate that this intermediate cell has two nucleus within the same cell and with perinuclear halo and very good contour. So this looks like a coilocyte. So many of these cells have the coilocytic feature. the NC ratio is relatively low, so we will consider that this is a low CO. So whenever we see a lesion, lesional cells in the conventional smear, if it is a precursor lesion, usually the distribution will be along the same smearing direction. So if you continue with the same direction, you will start to find more atypical cells. For this one, this is cells with multinucleation. The nuclear size is much bigger. So for the low CO cells, usually the size of the nucleus is 3 to 5 times bigger than the normal intermediate cell. So here you can see relatively low NC ratio, multinucleation, and with enlarged the size of the nucleus, and this is also low CO cells. So we go ahead and continue, and then we can see some more. So again, binucleation is abnormal, and we see vague perinuclear halo, and so this is considered as also callosity change. We also have superficial cells with multinucleation. So I think for this case, we have enough cells to make a definite diagnosis of low CO. Okay, so that's all the case for today.